Hey folks, this is Chad Duplantis here for today's presentation. And today we're going to be talking about something that may be burning on all of your minds, or it may be something that you just been thinking a little bit about. And the topic of today's presentation is: the crown is ready for delivery, now what? Simplifying cementation protocols for modern day restorations. As mentioned before, my name is Chad Duplantis. I am a dentist 4 days a week, Fort Worth, Texas. We have a restorative practice, a small group practice. I went to San Antonio for dental school. I did an AEGD at what was formerly known as Baylor. I received my FAGD in 2017. I've been a member of several aesthetic and restorative continuums throughout the years. Done Spear, done Seattle Study Club, and I'm currently a ambassador for the Seattle Study Club, which I'm very proud of. But one of the things that I'm most proud of is that I'm a co-founder and co-host of a social media group called Dentist in the Know. If you're not familiar with Dentist in the Know, I urge every single one of you to join our group. You can do so by following the QR code below. Dentists in the Know is a group that was founded for dental teams by dentists, and our job is to kind of keep you up to date with the current trends in dentistry. We talk about a lot of news. We have an influencer or an educator on every single week on our live show, and those shows are Wednesday evenings, and then they're transformed into a podcast as well as a YouTube production from the episode that is aired live on Wednesday evenings. So, without further ado, let's get into tonight's presentation. And I always start with this slide when I'm talking about cementation. It's one of my favorite questions, but it's also one that just kind of drives me up a wall. And we see this quite often if you go through social media. We'll find somebody that asks, what is the best cement for zirconia crowns? And it could say zirconia, it could say Emax, it could say PFM, it could say metal, it could say all crowns. And I don't think that it's necessarily a bad question, but what usually drives me nuts is the answers. And on this particular post, this was a while back. At the time that I screenshot this, there were 58 comments. And what I find most fascinating about this is that it was all opinion based. People are like, I use this, I use that. There was just a bunch of opinions. This is the best cement on the market. There was really, they were talking about products, they were talking about brands. And the thing that really drives me nuts is that a lot of the answers is that there's no rationale and there's no why. And recently, I've been reading a lot of these posts. I used to comment on a lot of them, and then I kind of stopped. But I've been reading a lot of these posts, and I'm starting to see that there's sometimes, nowadays, there's a rationale and there's a why. But I think it's really important that when we talk about cementation or final delivery of a restoration, we need to understand why we do what we do. And no pun intended on that, but if we don't understand the why, we're not going to understand how or what to use. So it's really important to understand the why. So hopefully we'll get to the meat of that tonight. The worst answer is, I want a retentive cement. And I hear that so often. I want a retentive cement. And we're going to talk about this in a minute. But the question that I present to you is there such thing as a retentive cement? And I just want you to hold on to that question for a little bit until we get to it in a little bit greater detail in a minute here. The real question that you need to ask yourself is it in the cement as to why a restoration succeeds or it fails? Or is it the cementer? And I heard that last week, and I really loved the way that that was presented. And I don't mean this to knock on anybody, because I'll tell you, when I got into cementation and when I got into bonding and understanding this, I realized that I personally didn't have a firm understanding of why we do what we do. And so in my case, it wasn't the cement that I was using. There's a lot of great cements on the market, but it was the cementer. So let's face it, tonight, or today, whenever you're watching this, There are a couple of reasons that you're here. The first is that you need CE. I'm not knocking that either. There's no reason that I should knock anybody that needs CE because we've all been there. The second reason is maybe you want to see a couple of new products out on the market and see kind of what's going on, or if there's any changes in cementation, and kudos to you as well. And the third reason is that you need some help. And in 2014, 2015, I needed help. I needed help with cementation. I was having debonds. Maybe I was rushing through things. But when it came down to it, I don't think I really understood the science, and I don't really think I understood the why. And so I personally did a deep dive, and I spent, don't knock me for this, but I spent 3 years really deep diving into cementation, and it's become one of my favorite things to talk about is cementation and bonding, which go hand in hand with one another. So moving forward, I think that every dentist, who's a good dentist and who cares about their patients and cares about the work that we do, which is hopefully every single one of you, suffers from a syndrome called restorative stress, and it's multifactorial. It begins with diagnosis. We may be the best diagnostician and we may need some help. And then we have to choose our prep and our material for each given case. We need to take an impression after we've prepped it and decided upon the material. Then finally, we need to come in and we need to cement or bond this restoration in place. And then we need to take into account occlusion. And all of these together lead towards the longevity of the restoration. You may be having struggles on one of these. You may be the best at all of these, but I think that hopefully somebody can walk away with a little pearl tonight that might help them in their practice. But we're going to focus today's presentation on cementation, of course. And to me, that was my biggest struggle in the years past. So when we think about an indirect restoration, we talk about prep, we talk about material, then we've got to think about cement. But we've also got to take into consideration the tooth. So you've got to take into consideration the material that you're using, the structure of the tooth, and then maybe that helps you determine the type of cement or bonding agent that you use in each restoration. So I would be amiss if I did not start this presentation by talking about perfecting the prep, because if you'll think back a few short minutes ago, you'll remember that I talked about one of the worst answers is I want a retentive cement. But what we've got to understand is that retention is not part of the cement. It's part of the prep. So let's go back to basics and talk about a good preparation before we get going into cementation. Every prep that we do, hopefully, would have ideal taper of 5 to 6 degrees. Now, this is for a full coverage restoration. You want an axial wall height of 3 to 4 millimeters. You want to avoid undercuts. You want to have an established path of insertion. You want to have sharp, well-defined cavo-surface margins. You want to have a smooth transition at the prep restoration interface, which leads to less plaque accumulation, less gingival irritation, and once again, longevity. You want to allow for adequate material thickness, and you want to have rounded gingival axial line angles, which lead to better restorative adaptation at the margins. Now, this is what we want when we think about a retentive preparation. Now, ultimately, this is not always possible because caries in previous restorations ultimately dictate the design of the preparation. So we may not always have a retentive preparation, but we need to start with this vision in mind and this type of preparation in mind in order to have success with a restoration. So one of my favorite diagrams to go to is from Glidewell Laboratories. I think it's very encompassing for all of the restorations that we're going to talk about. We want to think about having a 1 to 1.5 millimeter occlusal reduction, taking into account the requirements for the material that we've proposed for that particular tooth. We want to have a 1 millimeter middle third reduction. We want to make sure that our buccal and lingual walls are convergent, and our preparation needs to be cut in 3 planes. Finally, on both for an anterior or a posterior restoration, and this goes the same for bridges or fixed partial dentures as well. We want to have a 0.8 millimeter chamfer or rounded shoulder preferred. A feather edge is acceptable for certain types of restorations, but I'm a big chamfer person, so I would suggest that we go for a 0.8 millimeter chamfer, 360 degrees around the preparation. Now, what I always do in every preparation is I start with one burr. I start with this burr right here. It's a microcopy Neo Diamond 1812.8C. If you've ever heard me present before, you will know that this is one of my favorite burrs out there. This is more of a tapered diamond on the cutting surface. It's a coarse diamond. And the reason that I like this is that I can start every single preparation that I do and rough out the preparation with this particular burr. Another bonus on this particular diamond is that it cuts through zirconia. And a final bonus is that it's cheap. And so when we look at diamonds, I don't want to spend, I want something that's disposable. I want something that's inexpensive. I hate to call something cheap that works so well, but let's call it inexpensive. I want something that works. I want something that's inexpensive, and I want a workhorse. And this diamond fits that bill. So I rough out all of my preparations with this particular diamond. And then I come back with a coarse chamfer diamond burr, and I start refining my preparations. And once again, you just go over everything that you just did and you start defining those margins, maybe not cut to the entire depth, but get pretty dang close. And then you'll have a well-rounded preparation and a preparation that's ready to be finished and move on to the next stage. So here we are. Once I've used my micro copy, then I go to a coarse chamfer diamond. The one on the left is a coarse chamfer that is 1.9 millimeters at the shank, I'll call it, and 1.2 millimeters at the tip. When I know these measurements, you've always got to know your burrs. When I know these measurements, I know how deep I am on my cuts, and I know how deep I am on my margin. And then finally, after that, I will come back once I've roughed out the preparation and maybe left just, a tenth, 2/10 of a millimeter. I'll come back with a fine chamfer diamond, which is also 1.9 millimeters at the shank and 1.2 millimeters at the tip. And I will finish the restoration and I will make the restoration smooth. Once again, this is not always possible on every single tooth, but it is what we should strive for. We want to start with this particular preparation in mind that will lead us to success in our restorations. Now, I'm often asked, what is the rationale for preparation smoothness? Because some people will say, I don't really want a smooth preparation. I want a rough preparation, and that will, cement better. And you can find literature that differs on both sides, but I really like to follow the literature that leans towards a smoother preparation. And this to me just makes sense. This is a cited article. It's called Surface Roughness and Bond Strength of Enamel to Composite. It was from 1999, and I've just kind of followed this for years. Increased roughness of the preparation can undermine the enamel prisms and weaken the bond strength, whereas increased smoothness increases the surface wettability and enables more bonding agent and cement contact. That's what I want. I want more bonding agent, more cement contact, and I want to not weaken those enamel prisms. And so I want to go with a smoother preparation. I know that some people go as far as to polish their preparation afterwards, and I don't know that that's necessary, but I would say that a fine diamond will really get you the smoothness that you need in a preparation. Furthermore, let's move on. And we've talked about preparation because once again, without a retentive preparation, you can't have a quote unquote retentive cement. So let's talk about the cements or the agents that are available on the market for cementing these restorations. I like to refer to these as legacy cements and then modern day cements. So in the 1850s, we started with zinc oxide eugenol, which is still used today for temporary restorations and for hot teeth. I don't have a problem with that. And then we went to zinc phosphate, and then we went to zinc polycarboxylate, which was really interesting because zinc polycarboxylate is the first cement on the market although it was weak, but we started to see a bond of the cement to the tooth structure, which was really interesting. And then we got into glass ionomers. And these are what I like to refer to as the legacy cements. Some of you all still use them. I'm not going to discuss them today because I think today it's more pertinent that we talk about the modern day cements. If you use them and you're having success and you're having patient satisfaction and you're not having post-op sensitivity, I'm not going to knock you for using them. Don't change. If it's working for you, don't change. However, nowadays there's newer restorations and we have newer needs. And so the modern day cements started in the late 1900s, 1980s and beyond. We had resin modified glass ionomer, and then we had adhesive resin cements, and then we had self-adhesive resin cements. And we're going to break each one of these down and discuss them a little further as we go on. So when we look, we had the legacy cements from 1850s to about 1980-ish, and then we started with the resin modified glass ionomers, and that's where we're going to start today. Resin modified glass ionomers is really when I refer to cement, that's what I'm going to that's what I'm meaning is a resin modified glass ionomer. And you'll notice something else that's interesting. If you go through the progression of cementation, you'll notice that each one of these cement classifications really just changed one or two components to build upon one of the other components. And so if we look at this, starting with glass ionomers had a polyacrylic acid monomer, and then they had a fluoroaluminosilicate powder. And so when they came out with resin modified glass ionomers, you still had the fluoroaluminosilicate powder, but they replaced a portion of the polyacrylic acid with methacrylate monomer, which is hydrophilic, and that was to increase the bond strength of the restoration. Resin modified glass ionomers are of great need in today's clinical practice. The advantages of these is that we have good adhesion principles, and I say good because when we talk about adhesion, we're talking about bond strength. The bond strength is good, but it's not great. Their solubility in water was less than the previous versions of the glass ionomers. Now, we've always heard about fluoride release. Is that a good thing or a bad thing? We know that these can be recharged, but our hope is that where these can be recharged is at the margin. We hope that not enough of the margin is exposed to recharge these for the fluoride release. And with that being said, I don't want anybody to get under the assumption that if I have a resin modified glass ionomer that has fluoride release, I can just drop that right on a carious lesion. That's not necessarily true. So you definitely want to make sure that you've removed as much caries as possible. You want to make sure that you understand that the fluoride is going to be underneath the restoration, so it's not going to be able to be entirely recharged. And then finally, the final advantage is that the bond was greater than the previous version of the glass ionomer cements. Now, as far as disadvantages are concerned, our adhesion can be seen as a disadvantage as well, because although our bonding and our adhesion of these cements is there, it's just good. It's not great. So bond strength is a disadvantage compared to the newer versions of cements that are out there. And then we have newer restorations. We have more needs. Caries control is not really an advantage. It's more of a disadvantage because once again, you can't necessarily recharge what's underneath the restoration. And these cements do have it's gotten better, but a slight potential for expansion after setting. And so that's why a lot of people are fearful of utilizing these under lithium silicate or lithium disilicate restorations. Now, the newer versions, the more modern day versions of the resin modified glass ionomers have indications that can be used under lithium silicate and lithium disilicate restorations. So if you have a retentive preparation, a resin modified glass ionomer is a fantastic cement. Our indications for these are metallic crowns, porcelain metal crowns, alumina or zirconia restorations, cast posting cores, composite fiber posting cores. And once again, a newer indication of the newer resin modified glass ionomers is ceramic restorations. Ceramic restorations are an indication of the newer versions of the resin modified glass ionomers. So I like to put together a little bit of a wheel regarding all of our cements. And this is what I call the cementation success wheel. In the middle, we're always looking for adhesion, in my opinion. We want a cement that's going to adhere to the tooth. Red is bad, yellow is good, and green is great. And if you can look on the cementation wheel, you can see that the film thickness is good for resin modified glass ionomers. Solubility to oral moisture is good. Cleanup is good. Delivery is good. Color stability is good. It's not great. Most of these cements are white, so you don't want to put them under an extremely, or whitish, I should say. You don't want to put them under an extremely transparent or translucent restoration. But these cements are minimally irritating to the pulp, so they're a good cement. And I would say overall, a resin modified glass ionomer has some good qualities. And if you have a retentive preparation, this is a great cement to utilize in those indications. As we move forward, let's look at a new version of a resin modified glass ionomer from our good friends at Fuji. I'm sorry, our good friends at GC. They came out with the Fuji Evolve, and this is a wonderful cement because it has a great bond strength to zirconia. It has excellent wettability because they've incorporated a really long monomer chain that increases the hydrophilicity of the cement. So what this long monomer chain does is it allows the cement to fully wet the zirconia as well as to fully wet the tooth. And there's a chemical interaction between the polyacrylic acid and the zirconia. So when we look at the slide on the left of GC's Fuji Evolve, you can see by increasing that monomer chain, it becomes more hydrophilic, and you can see how it just flows into the imperfections or the nooks and crannies in the zirconia as well as to the tooth. And so this enables a higher luting strength. And on these other resin modified glass ionomer cements, you're not seeing the increased wettability of the zirconia or the tooth. And so you're going to have a decreased luting strength from those. When we look at a study, independent study from GC that shows us the tensile bond strength of GC Fuji Evolve, you can see that it performs well. Once again, I'm not going to say great, but I would say that it performs almost best to zirconia. It also performs well when we look at it compared to lithium disilicate, composite restorations, lucite reinforced restorations, and alloy. So this is a wonderful cement. And you're going to get similar bond strengths on the tooth. You're going to see 8 to 12 megapascals, I would say, of bond strength to the tooth. So you're going to get a good bond strength to the restoration, and you're going to get a good bond strength to the tooth, which really helps us when talking about luting strength. And so once again, for a retentive preparation and for the appropriate material, I would strongly recommend a resin modified glass ionomer. Now, the next may seem a little bit backwards to you because so many of us that have been doing this long enough are really fans of the self-adhesive resin cements. But believe it or not, the resin cements came out first. And so when we talk about adhesive resin cements, we know that there are multiple delivery mechanisms for these. There's a paste to paste, there's a single paste. They can be light cure, they can be chemical cure, they can be dual cure, they can require total etch, they can require self etch, and it really depends upon the cement and the bonding agent that's used. Now, these are also methacrylate based with a light or chemical initiator, which dictates the mode of cure. There is some sort of acid etch technique, whether it's self, total, or selective etch. The mechanical properties of these cements are good, and these do require a separate bonding agent in order to be successful with these types of cements. As far as our advantages with adhesive resin cements, their bond strength is very advantageous. Their compression strength is also an advantage. They have a low solubility to oral moisture, which is good because they're not going to wash away once they're in place. These cements provide us with the indications, and dependent upon the cure mode, if it's dual cure, these provide us with the indications for almost all of our restorations. And so our newer restorations needs were met with these adhesive resin cements. And dependent upon the type of or the brand of adhesive resin cement that you choose, the delivery can be seen as advantageous or disadvantageous. The disadvantages of these cements is that they can be extremely technique sensitive. If not done properly or not following the appropriate technique, they can cause postoperative sensitivity. And cleanup can be seen as detrimental because these cements have such a high bond strength. If it's not done in an appropriate manner and in a timely manner, it can be somewhat detrimental. So it's really important that one of my biggest things that I can tell you on these types of cements is make sure that you follow the manufacturer's recommendations. Nobody is going to produce a cement that causes postoperative sensitivity. So usually in these cases, and I'm not knocking anybody, it's not the cement, it's the cementer. And so follow the instructions, follow the appropriate technique, and you may not have postoperative sensitivity, and cleanup could be a breeze as well. Now, when we look at indications for adhesive resin cements, we have all of the indications that we need. We have porcelain and metal crowns, crowns with pore retention, alumina or zirconia restorations, inlays, onlays, veneers, composite, ceramic, or metal retained Maryland bridges, cast posting cores, composite fiber posting cores. And the one indication that we did not see on the resin modified glass ionomers is veneers. And of course, it's here on adhesive resin cements. So in my opinion, whenever you're cementing a inlay or an onlay or a Maryland bridge or a veneer, you want to use an adhesive resin cement because you're going to get the maximum bond strength. There are multiple variations of adhesive resin cements on the market. We have self-cure, which I don't know of many people that are still utilizing the self-cure, but some people that have used it for a long time swear by it. And so there still are some self-cure adhesive resin cements on the market. The majority of those that are marketed as veneer cements are going to be light cure. And so there's several variations and several brands of that. And then nowadays we're seeing a lot more dual cure adhesive resin cements. And you can see that there's multiple variations of those dual cure adhesive resin cements. It's really in your preference, what you feel works best in your hands and what you feel works best for your patient population as to which direction you're going to go. Personally, I'm a big fan of the dual cure adhesive resins. Some people will disagree with me on that, but I'm a big fan of the dual cure adhesive resin cements. When we get to adhesive resin cements, you can see that our color progression wheel of cement success is a little bit more lit up with green. We've got minimal film thickness. We've got low solubility to oral moisture. We've got color stability, and we've got really good adhesion. As far as pulpal irritation is concerned, I'm going to say it could go either way. But once again, usually when we get something that's pulpally irritating, we need to look back at what we did and what we could have done to prevent that, what we could have done differently to prevent that. Cleanup, if you follow the manufacturer's directions, these can be very easy to clean up. If you wait too long, it's going to be tough. And delivery is really dependent upon the brand that you choose. Most of these are a single syringe system now or a dual syringe system. And that makes delivery a breeze, as we know, compared to the old, some of you may not remember this, but the old glass mixing pads. So delivery in my mind, of the adhesive resin cements is very advantageous. And there's several brands on the market. Like I said, you know, feel free to ask me any questions after today's presentation with brands that I recommend. But they're all really good, or I wouldn't share them in this presentation. It's all user preference, what works best in your hands, and I would suggest definitely following the manufacturer's directions. And before we go too much further, one of the things that I also wanted to discuss is our bond strength. Our bond strength is really dictated by the separate bonding step. These adhesive resin cements require an additional bonding step. One of the things that I really recommend is, if you're going to choose 3M or GC or Voco or Kerr, make sure that you use the bonding agent that is recommended by the manufacturer for that particular cement. The cement and the bonding agent are manufactured to work together. They're going to work best together when you keep it under the same roof. The chemistry will be the same, and they're designed to work together. So if you choose one brand of cement, make sure that you choose the appropriate bonding agent. This is an example of GC's Link Force, which is GSEM Link Force, which is their adhesive resin cement. So one of the things that I want to point out is, with GSEM Link Force, it has a really high filler rate. And so you have a low film thickness, which we talked was advantageous of the adhesive resin cements. It has a high polishability. It has less plaque accumulation at the margin, which leads to low wear. So I like this because it flows really nicely underneath the restoration and onto the tooth. And so we have a 4-micron film thickness, which is very good. It's not going to distort the seating of your restoration, and a filler rate of 62%, which compared to some of the other competitors on the market is very impressive. Moving on, this is the one that's probably foremost in our minds, is the self-adhesive resin cements, but they are one of the newer versions. And I will remember how great this was when they first came out. They came out after the adhesive resin cements. When we talk about self-adhesive resin cements, what do those look like? Well, self-adhesive resin cements are dual cured. They're acrylic diacrylate monomers and specific adhesive monomers that are acidic enough for self-adhesion. So the difference in this is that these cements are not going to require that additional bonding step. They're somewhat, quote unquote, universal in nature. They have a lot of indications, and they don't require the additional bonding step because of these adhesive monomers that are acidic enough for the self-adhesion. These adhere best to the dentin of the tooth. We leave the smear layer intact for utilizing these cements, and there's no etching step. So this is very attractive to many of us consumers on the market, because there's no etching step, there's no separate bonding step. How great is this? When we look at their advantages, they're single step. Their cleanup, they have a lesser bond strength than the adhesive resin cements, so the cleanup is much easier. But once again, if you leave these on too long, they could be a bear to clean up. They have a good bond strength. I would say that the bond strengths of the self-adhesive resin cements is maybe a little bit greater than resin modified glass ionomers, but they have a good bond strength. And these have minimal effect on postoperative sensitivity. So, we're not going to get our patients coming back with screaming teeth. And so that's nice to dentists as well. The disadvantages of these is that these used to have a problem with color stability. And that's why when these first versions came out, veneers were not indicated, or translucent restorations, it was not indicated to seat with a self-adhesive resin cement. However, this has changed in time. The majority of these are amine-free and benzoyl peroxide-free, which leads to a greater color stability when we talk about the problems of these cements in the past. Additionally, the bond of these cements is less. Let me repeat that. The bond of these is less than the adhesive resin cements. So this becomes disadvantageous when you're looking for maximum bond strength. Don't try and shortchange yourself. If you've got a non-retentive prep, go with an adhesive resin cement versus a self-adhesive resin cement, because what's going to happen is you're not going to get as great of a bond strength as you could with the adhesive resin cement. So the bond strength could be seen as disadvantageous for those non-retentive preparations. And we'll talk about that in just a minute. So when we talk about the indications, we're going to see metallic crowns, porcelain and metal crowns, aluminum or zirconia restorations, inlays and onlays. I would tread lightly on that, although it's an indication. I prefer to bond those. I would also tread lightly on Maryland bridges. I want maximum bond strength for my Maryland bridges. But on these, you can utilize for cast, post, and core, and you can also utilize for composite fiber post and core. So although these are indications, the three that I would steer clear of would be inlays and onlays and Maryland bridges. In my opinion, those are better off bonded. And you'll also note that these are not really indicated for veneers. Although color stability has changed, I want to bond my veneers in place. Veneers are a bonded restoration. I want to have maximum bond strength. So I want to use a bonded cement or a bonded adhesive resin cement. When we look at the color wheel, it's a little bit more vivacious as compared to the adhesive resin cements. And that's because cleanup is a little bit easier. But once again, dependent upon what version, if you're utilizing an older version, color stability could be an issue. This is with the first versions of the self-adhesive resin cements, and nowadays most of that has been alleviated. So you just want to make sure that you're using one that's benzoyl peroxide free and amine free in order to enhance or see minimal color change or have maximum color stability, I should say. And then here's some versions of what's out there on the market. There's several great self-adhesive resin cements out there. Once again, it's user preference as to what brand you're going to decide to use in these instances. Now, when we talk about the tensile bond strength to dentin, what I want you to notice is that for the majority of the cements out there, the tensile bond strength to dentin in the self-cure mode only for this is going to increase as time goes on. So after 5 minutes, you're going to have a low tensile bond strength. After 10 minutes, that bond strength is going to be increased. And after 20 minutes, it's going to increase even further. But what I'll also like you to notice is that as far as the tensile bond strength, it's really not that much greater than resin modified glass ionomers. So this is still not going to give you your maximum bond strength, whereas an adhesive resin cement is going to give you your maximum bond strength. One thing that you'll notice is also after 5,000 thermocycles, which is basically similar to simulated chewing or simulated time in the mouth, days in the mouth. After 1 day, you're going to have your maximum, but after several thermocycles or after several days or months or years in the mouth, the tensile bond strength to dentin is going to decrease ever so slightly as well. And that goes across the board. Now, when we talk about our three modern day cements, we've got, once again, our resin modified glass ionomer, our self-adhesive resin cement, and our adhesive resin cement. Now, when I mention these three, you'll notice it's different than the way that I previously mentioned them, but that's because as we go through this is the way that our bond strength increases. So, our resin modified glass ionomer is going to have our least, our self-adhesive resin cement is going to have more, and our adhesive resin cement is going to have our highest bond strength. However, today we now have a new cement that I think many of you will be interested in, and this cement is a self-adhesive cement and an adhesive cement combined into one that you can utilize with or without an optional adhesive step. So what this new classification of cement does is it affords us to have one product in the cement that can be used with, if we want maximum bond strength, or without an optional adhesive step if we don't want that maximum bond strength. So this is truly a plug and play, or it's also the addition of an adhesive step, which will enhance your bond strength. I think this is really innovative. There's a couple of products on the market out there right now that are in this category. We've got GSIM 1, and we also have 3M RelyX Universal. And one thing that I can say about this is that when the self-adhesive resin cements first came out, we really thought that it was a universal cement. But what we found now is that this is, in my opinion, truly universal, because this can be utilized on all restorations and meet the needs of every practitioner. So it minimizes our inventory and maximizes our efficiency when we're talking about cementing or bonding restorations. So let's talk a little bit about these cements. When the cement layer is thick, and I always ask, when you get a restoration back from the lab, do you know how thick your cement layer is going to be? Do you know how many microns of spacer they put on that digital or that stone model, which is going to account for your cement gap? Do you know what that spacing is? I would like to say that the majority of us would have a pretty good idea, but the facts are is that most of us don't know. So what happens is that when we place a resin cement underneath that restoration, and we irradiate it with a light or it self-cures, it's going to pull away from the tooth. And so you can have shrinkage stress, which is definitely going to be greater on the crown side when you use a light to irradiate that. So what we find is that our shear bond strength is going to be less when we have a greater cement gap. So from 50 microns to 200 microns for that cement gap, you're going to notice that we have a substantial decrease in our bond strength. So here we are, we're talking about GSIM 1, which is their new universal cement. GSIM 1 has an adhesive enhancing primer. So what you can see on the top on a 50 micron restoration, this right here is the cement gap. Without the primer, you're not going to see a cement gap under electron microscope. With the primer, you're not going to see much of a cement gap. But when you go to a 200 micron restoration, you're going to get that shrinkage stress. And without the primer, you're going to have peeling at the interface, which weakens the bond, not to the restoration, but to the tooth. So you've got peeling at the dentin interface without the primer, but when you put the primer in there, you're going to see it's pretty much the same as it was at 50 microns. So you're going to get that increased bond strength, which is important to us all. So here we are. You can see 50 microns and 200 microns with the adhesive enhancing primer. You're going to have a very similar bond strength, only a slight decrease on that 200 micron. Without the primer, you can see a more drastic decrease, but you can also see that without the primer, that the shear bond strength is less on the 50 and the 200 micron. It's just more pronounced on the 200 micron. So the point of this slide is to show that the adhesive enhancing primer increases the bond strength, and that's the bonding agent that we're discussing. So when we look at a dental advisor study, this is not an internal study, it's an independent study. You can see that to enamel, the shear bond strength was greatest on the GSIM 1, and it performed very well with and without the adhesive enhancing primer. On dentin, you can see that GSIM 1 plus the adhesive enhancing primer really boosted that bond strength. And then on lithium silicate and zirconia, you can see that the GSIM 1 performs very well. Now, the adhesive enhancing primer is to be used on the tooth, which we'll talk about in just a minute. And then you'll want to use a primer on the intaglio surface of the restoration. So now that we've talked about I would say, 4 new versions of cements, it's really nice to have one that's all in one. And I think that this cement does just that. So let's talk about the restoration as we close out this presentation. The restoration, this is a classification from Dr. Ed McLaren. I love this classification. We've got glass restorations. We've got bonded layered porcelain and glass ceramics on the left. And then on the right, we have infiltration ceramics and solid centered monophase ceramics. And you'll see that the internal composition, which we won't get into too much, is quite different on these 2 restorations. And the glass restorations and the glass ceramics on the left are etchable. The ones on the right are non-etchable. And so for these purposes, they recommend to bond the etchable restorations, and the restorations that are non-etchable, you can cement or bond. Now, glass ceramics nowadays, we can cement those because of the newer versions of resin modified glass ionomers. But once again, if you've got good retentive properties. So let's look at what I would do. This is my opinion. This is from Chad Duplantis. What I would do on a zirconia restoration, I would cement or utilize resin modified glass ionomer if retention allows, and I would bond if it's a non-retentive or a highly translucent restoration. On a glass ceramic restoration, I'm going to bond. I'm sorry. I always bond my glass ceramic restorations. I want this restoration to be as strong as possible. We know that the restoration strength increases when the strength of the bond increases. So I want to bond all of my glass ceramic restorations. And another classification that we really haven't talked about much, but these are the hybrid ceramics. You've got several blocks out there that are CAD-CAM. These blocks are infiltrated. They're resin infiltrated with a ceramic or zirconia particles. On these, I only bond these restorations. I find that I get maximum strength, and I just don't have issues after I bond these restorations. Now, when we're talking about the restoration, rule number 1 is you always need to know how your lab treated the restoration. What I mean by that is the restoration, if it's zirconia, is it coming back from the lab sandblasted? If so, you don't need to sandblast it again. If it's a glass ceramic restoration, is it coming back from the lab etched? If so, you don't need to etch it again. So always know how your restoration is treated by the laboratory. Rule number 2 is read the instructions. Read the instructions, understand the material that you're cementing, and understand the cement that you're going to be cementing it with. So let's talk about zirconia real quick. On zirconia, these need to be air abraded. If not done at the lab, you need to do it in your practice. 50 microns or less particle size, 45 pounds per square inch or less air pressure. And then I always recommend a zirconia primer. There's several out there on the market. A multi-primer will work as well. And the key ingredient of these is 10 MDP. Monobond Plus works on all restorations. ZRP from Vista Apex, although you would think it only works on ZRP, it will work on all restorations. And then GC's multi-primer will work on all restorations as well. So just make sure that you read the instructions, you read the ingredients, and you understand what you're utilizing. So on glass ceramic restorations, we want to utilize a 5% hydrofluoric acid etchant for 20 seconds. This is for Emax and lithium disilicate and lithium silicate restorations. Following that, if it comes from the lab etched, you don't need to etch it, but after you try it in, you definitely need to clean it out. There's several products on the market. There's Ivaclean from Ivaclar. There's ZRC from Vista Apex. These are great products. Dr. Nate Lawson has a great study with other products that you can utilize to clean the intaglio surface, but I'm going to use a cleanser to remove the contaminants such as the blood and the saliva that may get underneath these restorations and inhibit our bond strength. And then finally, you want to apply, in these instances, a silanating agent, but the 3 products listed below can work as a silane or a zirconia priming agent. Just make sure you know what you're using. Monobond Plus from Ivoclar, Multi-Primer from GC, and then ZRP from Vista Apex. There's several other products out there. These are just 3 that I just wanted to share for comparison purposes. And then rule number 3 is you want to make sure that the retention is evaluated and the tooth is properly cleaned. So here's the process. You first need to evaluate the preparation. The one on the left is a retentive preparation. You can cement that with resin modified glass ionomer. You can cement it with self-adhesive resin cement, and you can cement it with adhesive resin cement. If it's an opaque restoration, you need to make sure that you're utilizing a dual cure cement. The one on the right, I'm sorry, folks, but you have to bond it. Nothing is going to stick to that tooth that's not bonded. So it's really important that we evaluate our preparation. That is a non-retentive preparation. So for adhesive resin cements, we need to do a phosphoric acid etch or some sort of etch on the tooth. Follow the manufacturer's recommendations for the bonding agent that you use. On all cements, you need to properly cleanse the tooth. If you have not properly cleansed the tooth, then I'm sorry, it's not going to work. And I hate to tell you that in order to properly cleanse the tooth, sometimes the patient needs to be numbed. I like to use a chlorhexidine-based product. There are several out there, but one that I'll mention is HemaSeal Inside. It's 4% chlorhexidine with Hema, so it's going to eliminate microbial activity, and it's going to enhance bond strength through the Hema that's incorporated in it, but make sure that you have a clean tooth. If you're utilizing an adhesive resin cement, you need to use the optional adhesive step. And then finally, you need to place your cement in there. So on a retentive preparation, what are we going to do in this instance? If I'm going to cement this restoration, if it's retentive, I'm going to utilize resin modified glass ionomer and a self-adhesive resin cement or a self-adhesive resin cement. That's all you need. Make sure the tooth is clean and then utilize resin modified glass ionomer or a self-adhesive resin cement. If I have if I'm going to bond this restoration, which I certainly can, I'm going to use an adhesive resin cement, and I'm going to use a universal adhesive or an adhesive enhancing primer on the tooth and follow the manufacturer's instructions for the intaglio surface of the restoration. For a non-retentive preparation, I'm sorry, on a preparation like this, you have one choice. You need maximum bond strength, so you're going to utilize an adhesive resin cement and the universal adhesive or the adhesive enhancing primer. Make sure that you utilize what the cement requires to bond to the tooth. And I will tell you that if you follow these principles, that you're going to have success time in and time out. So let's break down a case with the newer cement formulation. And in this case, I'm going to utilize GSIM-1. So here's the patient that presents to my practice. Patient comes in and we're going to replace 8 and 9 with full coverage restorations and 7 and 10 with veneers. Here's my preparations. You can see that, yes, I do have retentive preparations, but I'm going to use Emax. And when I use Emax on this particular case, I want to bond it in place. So here's my preparations. Patient comes in with their temporaries. Remove the temporaries. We evaluate the restorations prior to cementing. These are Emax restorations from my lab Sunflower Dental Studio in Topeka, Kansas. And the first thing that I'm going to do when I evaluate this restoration is I'm going to look at the intaglio surface. Did this restoration come back from the laboratory etched or not etched? On a lithium silicate or lithium disilicate restoration, you're going to see a white frosty coating on the intaglio surface of that. This restoration came back etched. I don't need to etch it again. So once I try it in, I'm going to clean it with some sort of cleanser that's going to remove the contaminants prior to bonding it. So I'm going to cleanse it, scrub it for 20 seconds, rinse it out, and I'm good to go. At that point in time, I'm going to treat the intaglio surface of the restoration, in this case, with G multi-primer, because that's what's recommended for the GSIM1 cement. I'm going to let that air dry. I'm going to make sure that my preps are properly cleansed. So I'm going to cleanse the prep with Hemoseal Inside or some chlorhexidine-based cleanser. And then I'm going to utilize the adhesive enhancing primer that's going to increase my bond strength to the tooth and decrease my restoration shrinkage away from the tooth. At that point in time, I've treated the tooth the way that it needs to be. I've treated the restoration the way that it needs to be. I'm going to go ahead and introduce my all-in-one cement, my GSIM1, into the restoration. I'm going to place the restorations in place. I am going to just briefly cure these restorations for 2 to 3 seconds. I am going to remove the excess cement. After I've removed the excess cement, I'm going to let that cement set for 4 minutes in the dual cure mode, or I can go ahead and light cure all surfaces and margins. But before I do that, I want to make sure that all the excessive cement has been removed. At that point in time, I'm just going to go through, after my final cure, I'm going to go through my polishing steps. After after I've ensured that the restorations are cured, I'll go through my polishing steps. And right before they leave, I usually just tack the restorations for 10 seconds on each side just to ensure a final cure. And these restorations are ready to go. All right. Now, remember, this is a dual cure cement. This last step is entirely optional. This is just me kind of being a little bit overzealous on my behalf. 10 seconds from the facial, 10 seconds from the lingual or palatal on each of these restorations. And then voila, here's our final restorations. So you can see it's a great product. On this particular case, since it's anterior, I'm using a glass ceramic. I want ultimate bond strength. But on a posterior, if I've got good retention, I don't need the adhesive enhancing step. I can use it with or without, but I want maximum bond strength. I want the decreased shrinkage from the tooth. And so I feel that I'm going to get the best result by utilizing that adhesive enhancing primer. So as we close, I just want to share with you, if you have any questions, my email is real simple, drduplantis.gmail.com. If you'd like a copy of this, this is what I call my cementation cookbook. Feel free to email me, and I'm happy to share this with you. I'd also like to share with you that our educational sponsor tonight, GC, has a wonderful app that's very user-friendly that you can use to actually just go through. Obviously, they want you to use GC cements, but if you're not, and you understand resin modified glass ionomers, adhesive resin cements, and self-adhesive resin cements, the information in this app is extremely useful, and it breaks down the cases, the instructions, and how to choose cements. And so finally, if you have any questions after this, or if you'd like to get in touch with me, I would hope that you would feel free to do so. And I'd also encourage each one of you to join our group, Dentist in the Know. We'd love to have you. I know it's a lot of information, and sometimes I feel like I'm drinking through a fire hose when I'm trying to get this information. I apologize if it's confusing, but just, go back to it. Feel free to ask me for the cementation cookbook. I try and update it regularly with any needs. And I hope that you got at least something out of this. So I appreciate your attention. I thank you for your time. And please feel free to reach out if you have any questions. Thank you.